Hello, Dosto, from my beautiful Fertility Dost community. I am Gitanjali Banerjee, founder of Fertility Dost, and I'm here in conversation with Dr. Soumya talking about a very important topic, infertility. And today we are going to focus on the early diagnosis with the aim that you can prevent infertility or prevent it from escalating it into a bigger problem. So, our aim is that you are informed of what are the factors which can cause infertility, what can be the roadblocks or the hurdles, what can be the early signs or symptoms that you can keep a watch, especially when you are trying to conceive or you are planning to conceive in, say, next 6 months or 1 year. The incidence of infertility has been increasing all across India. A recent report by WHO says that 1 in 10 couples go through infertility, and the number of couples going through infertility are much higher in the metro cities, especially with couples working in the high stress environment of corporate, IT sectors, or both the partners working. It basically changes their lifestyle and also leads them toward late pregnancy plan. So we're going to talk about these aspects and a lot of other things. And you're free to ask your questions in the comments, and we'll try to answer and resolve as many of your doubts as we can. So let me introduce and bring on our doctor, Dr. Soumya. She's joining us from Chennai. Hi, good evening, Dr. Soumya. How are you?
Hi, good evening. I'm good. Thank you, Gitanjali, for having me here.
It's completely our pleasure, Doctor, and thank you for making the time to build this awareness. We have been doing these webinars by esteemed doctors like you because we want to bring the factual, medical, and scientific information to users. Otherwise, Google to hai, लेकिन Google confuses the people more than it.
Exactly. Yeah, people get so worried after going through the Google. So it's better to have authentic information, and you're doing a good job by creating awareness.
So I would like to start today's conversation by asking that from a doctor's perspective, and you are meeting so many couples every day, why do you think this problem of infertility has increased lately? And what can we do to yes? Okay, let's start with one question.
See, it has increased, as you said, most importantly because couples are choosing to become pregnant much later in their lives. Their career is first they are more worried about their careers, stabilizing in their careers, and then starting a family. More so, even marriages they keep postponing for want of a better secure place in the society, in their careers, all those things. And then finally, when they're kind of settled, then they go in for thinking about babies and all that. And still, even the mindset of youngsters is different now. Not all of them want to have a baby anyways, but for people who do want to have a baby, it is like sometimes they come at the age of 35 after they come to a big position, and then they are relaxed to think about a baby. But our biological clock doesn't always go with our career goals. Biological clock is constantly ticking, and we need to be aware of that. That is the main purpose of this talk or conversation, because the young women should know that they can't think that their fertility lasts forever. So that is the most important thing. Age is a single most important factor in fertility. Next comes your lifestyle. Basically, I think this generation is more stressed out. It's understandable because the competition is so much. And their ambitions are much more. So it looks like they're constantly under some kind of an emotional stress. So to add to it, I would say that it's not only the physical factors, it is also the mental factors, the emotional factors, which play a major role in fertility. Also, the relationship issues, because it's like everybody has their own independence, and I don't think women these days would just listen to elders or to their husbands all the time. They have their own thought process going, and so I don't think they would be just subdued by anybody. So taking all those into consideration, I think childbearing has taken a backseat. But when they really think of it, sometimes the time is too late.
Yeah, absolutely agree. A lot of changes has happened in how the society is looking at the whole childbearing as an process in the life journey, and how youngsters are having a changed mindset. And yes, so one of the factors of infertility is late decision or higher age when they actively start to think conceiving. I want to add on to this and build up and ask you that what are the main medical issues that you see or the complications? I also see one of our users has already asked the question of that there are many complications these days. So what are those? So what are those main maybe 4 or 5 issues which you see common among couples who come to you for infertility and at an early stage, maybe 1 year they have tried, 6 months, 1 year trying. So what are those issues?
Basically, I would say issues as such. One is the knowledge about the fertile period, which some of them have, some of them don't have. That is one thing. Secondly, most of them have an ovulatory problem, because basically there is some hormonal imbalance which goes on because of the lifestyle or for whatever reasons. So there is an ovulatory problem which is going on. Similarly, also on the male counterpart, the semen parameters have come down drastically, probably because of the lifestyle or and also because of the stress. Other thing is because of the late planning of pregnancy, sometimes we also have issues like fibroids or endometriosis, which start of creeping in as the woman advances in age. So I would think these are the most important things which I see in day-to-day practice.
So, what are the practical steps that these couples can take before they reach out to the doctor? So, we'll distribute it into the phases. The first phase is obviously all of us know that they will try it on their own. Maybe they can, you know. So, at that stage, what should they think? One of the very good points that you said, and we also face a lot of times, is that they might not even know about the ovulation time
Exactly,
or the fertile
exactly,
period.
exactly.
So,
Exactly. So, what I would like to say is first, awareness about the fertile period is very important. And, they have to understand if it's a regular 28 or 30-day cycle, it is good that they start trying from day 8. By day 8, I always mean from the first day. Day 1, when they get their period, would be day 1. From that day till you calculate the 8th day, and from the 8th day to the 18th day, every alternate day, it is better to try in a regular cycle. If it's a kind of an irregular cycle, we wouldn't know when the ovulation process takes place. But a rough guide would be to check your mucus, cervical mucus, which is coming out, which would become thin and stretchable. It is when you do this, it will be stretchable like a string. That means around that period you will be ovulating. The other thing is you have these commercial kits called the LH kits, which will roughly tell us when you're ovulating. Say it's like a urinary pregnancy card. When you put the urine and you test, if it is if it turns positive, then it means that within 24 hours you might be ovulating. So that would be a time for you to try, because many of you all are working and trying every day or every alternate day. If you have an irregular cycle, may be really difficult. So these could be markers to tell that you can try around that time. But the best thing would be to have an ultrasound follicular monitoring, which will tell us when you're exactly ovulating. But these tips are when you're trying at home, before you reach the doctor. So this is like a practical tip to know when you're ovulating and to try around that time in case of irregular cycles. If you have regular cycles, it is from day 8 to day 18 every alternate day. So that is knowledge about ovulation. The second thing is you also should change your lifestyle. Both of y'all, both the husband and the wife, should realize that healthy lifestyle should be started right from the time you're planning for a pregnancy. Because by healthy lifestyle, I mean eating right, maintaining an ideal body weight. So it should not be overweight and even underweight. Some people are very paranoid about the weight, so they eat very less, they exercise more. Even too much of exercising and eating too little when you're underweight, again your hypothalamic pituitary axis is kind of shut down. So ovulation may not be happening properly even when you're underweight. So you have to understand that it's not only overweight, it's also underweight. So maintaining an ideal body weight is important. Also, you eating right, the right kind of food, healthy food like fruits, vegetables, a little bit of dairy. Not that dairy should be totally avoided, but again, permissive limit of dairy should be taken. Also, your avoidance of substances like avoiding smoking, avoiding alcohol. See, alcohol, social drinking once in a while is fine, but when you're really planning or when you become pregnant, it is better to totally avoid alcohol. Also, caffeine, restrict the number of cups of coffee you take. Say 2 cups is all right, but anything more than that, you have to watch out. Also, avoiding any recreational drugs, or and avoidance of exposure to chemicals, pesticides. This is more for the male counterpart, so it's better to avoid any chemicals which you come across, in your supposing you're occupationally you're exposed to those. It's better to avoid all those. And again, exercising is very important because it is good, especially for both partners, because exercise avoids obesity. The other thing is it also releases the good hormones, and that makes your general stress levels, it reduces your stress levels when you're exercising. So maintaining a healthy lifestyle is very important when you plan for a pregnancy, and so even when you're trying for a pregnancy, because all these, maintaining an ideal body weight would help your ovulation process to be on track. So before coming in, you will have to probably try for at least, say if you're a young woman, you can try for at least a year before you reach the doctor. But if you're much older, say around 35, then about 6 months you can try on your own. And then you can, if it's not happening, you can seek medical help.
So thank you so much for explaining me in detail about the practical steps that they can take on their own. And in fact, my next question was this only, that when should they reach a doctor, and that you have already answered.
Yeah,
That
1 year, if they've been trying regularly on these days, specified days, uninterrupted intercourse is unprotected intercourse on these days, then I think a year is sufficient. Most of them would conceive. But if they are young and they still want to wait, even waiting for 1 more year is fine. But ideally after 1 year of trying. But if they're much older, I think 6 months would be the time frame, and I think they should reach.
okay. So that, I think, very much gives them a blueprint of what they should do, and so that they don't keep waiting eternally.
Exactly. Because many of them think that they have time on their hand and they keep endlessly waiting. No, doctor, I would like to wait for some more time. See, that is it. So if it's younger, I think it's okay to wait. Otherwise, I think you should come in straight.
So when you say younger, is it you're saying below 30 or below
35. Actually, I will tell you, 22 to 26 would be the peak fertility time. Even say that the fertility peak would be maximum between 22 to 26. After that, there is a gradual decline, but still 30, it is still all right. After 30, there is a decline in the fertility, and after 35, there is a drastic decline in the fertility rate. 40 onwards, I think it is definitely very, very low. So time, the age is a very important factor.
And so, doctor, once let's say that they are, am I audible?
Yeah.
Okay. So, say whichever age bracket they fall in, which you just told, and they decide to meet the doctor, what should they expect when they reach a doctor? Because a lot of couples, the reason that I know, and we at Fertility Dost deal with many of them, is that they keep procrastinating or not going to a doctor because they think once we go to the doctor, there'll be a lot of tests, a lot of medicines, and there's a feeling of scare. What would you tell them? What should they expect in their first maybe 1 or 2 visits?
Yeah, right. First, when they come in, I would be asking them a bit about their history, about their sexual history also, because that is very important. As I said, many of them are unaware when they should try. When I ask, for example, they would say once a week. See, once a week is not all right. You should, in those days, between 8 to 18, it should be every alternate day or every day if possible. That's a very important thing. Secondly, they also, their work schedules are, not matching each other. Some people work in the nights and then they say they're too tired, and then, that is how it is. So, first, about their sexual history, how often they have intercourse is one thing. Secondly, I would probably probe a little bit into their medical history and any surgical history if relevant. And then we move on to the basic investigations. I don't think anybody should be really worried, because we would be just ordering the basic investigations. First, for the husband, it's a very simple test, which is the semen analysis. That itself will tell us, whether everything is okay with him or not. So, a simple semen test with, probably 2 to 3 days of abstinence, and then you give the sample, that would tell us whether things are okay with him. And for the woman, probably I would be just ordering some blood tests. This is to see if there are any other medical conditions, and then probably we would be doing an ultrasound. That is the basic. So based on this, we would move on to any further testing. If all these are fine, and your basically your menstrual cycles are fine, that is between 21 to 35 days, then I think we could still wait for some more time before we start off with a little more testing.
So at this stage, are some medicines or hormone injections also prescribed to them, given that PCOD, PCOS cases are very high these days? In fact, I saw a few of the comments where they're asking about PCOS, PCOD, how do they deal? And that is also the case where the period cycles are not very regular. So
Exactly. So when the period cycles are fine, these are the basic tests. When the period cycles are not okay, like PCOD, where the cycles come once in, anytime between 45 days to 2 months, 3 months, then we'll have to look at their weight. Basically, weight reduction itself will treat most of these girls. It would make them conceive. So at least, the ideal BMI should be between 19 to 26. But if they are at least able to lose 5% of their weight, then the ovulation resumes so well, and so they will be able to conceive naturally, even without medication. And some of them are exercising, but still they are not able to lose weight. Then we have something called metformin, which we do give for the PCOS to alter the metabolism so that they start ovulating better, and a few adjuvants which will help to set the metabolic milieu right. So that is what we do in the initial stage. Also, we prescribe folic acid, which is like, when you're planning for pregnancy itself, we start off on folic acid. These would be the basic things which we would do.
Oh, no. So, friends, you have understood that the first stage is when you are trying on your own, and Dr. Soumya has already given you a lot of practical tips that you can do at your home. Be mindful, be careful. Of course, lifestyle is extremely important, and don't worry, Fertility Dost is there with you for the lifestyle management. The second phase is when you actually reach the doctor, and then you have experienced doctors like Dr. Soumya, and you can reach out to her and just have a chat. So there's no scare. You can always tell them that, I'm not ready for any massive treatment right away. I'm just here to talk to you or understand my ovulation, understand my body. So, friends, please understand that doctors are there to help you. They are not there to scare you. You can always go to them. And it is not that in the first visit itself they are going to put a lot of injections or give you a huge list of treatments. Trust me, doctors these days have changed a lot. The younger doctors like Dr. Soumya are much more understanding. They understand. They know that couples like us have a hectic life schedule, and they might not have the time or that kind of energy. So the protocols are also simplified as per what you and your lifestyle requires. So just talk to them with an open heart.
Yes, Gitanjali. Sometimes they get stressed. The moment they see, so at least to put them to ease, it's always better to go by how they want, at least for the initial few months, till they come to term, they understand you better, and then they are okay to listen to whatever you say. So, yes.
Absolutely. That's why I wanted to say it very loud and clear to all the people who are hearing us and our new friends who are joining our webinar or watching us. because this is the biggest problem, the emotional, the mental problem, the breaking the mental barrier is what we have seen. Or
Exactly.
once they are comfortable with the doctor, then together they can decide what
Yeah.
path to take.
They are more
So from
receptive
here,
also once they are relaxed. Till that time, I think it is, yes, yes.
Ji, absolutely. But another thing which is I wanted to highlight here is that a lot of couples feel that the moment we go to the doctor, there will be invasive treatment because uh, uh, there has been a lot of awareness about IVF per se. So people think that if we go to a fertility doctor or fertility clinic, and you won't believe there's so many of us who come to us and say, Ki, no, we don't want to meet a fertility doctor. Just tell us a gynae, and we tell them that okay. So a lot of times both can be same also, and
Exactly.
different also. It doesn't matter. It will depend on your medical background. But Dr. Soumya, I want your help to put light on what are the initial non-invasive treatment methodologies that we can use. The couples who are experiencing delayed pregnancy, they can use so that they have fair idea of how the balance works. ऐसा नहीं है कि you have to immediately go for an IVF. So what are the other technologies that they can
See,
use?
basically, we don't jump to IVF for anybody. First thing is, we'll have to check, as I said, a basic ultrasound, which will tell us whether the uterus is fine, whether the ovaries are okay, whether the ovaries are appearing normal or polycystic. That is one thing. Then, if they are young with no other abdominal surgeries or any other infections, past history of any of those, then we don't suspect anything with their tubes. But if they've been trying for a year correctly on those days and still they're not able to conceive, then probably it would be a good idea to check on the tubes. Again, tube testing, we have several methods of testing. One is we inject a dye because see, three major factors. One is the uterus, the next is the tubes, and we have the ovaries. So all three have to function in unison to have a good pregnancy. So first thing is ovulation. That I said we'll have to look at the ultrasounds to see. We do something called the follicular monitoring where we track the eggs. So which means from the 10th day onwards, we do a transvaginal ultrasound. It's important to understand that ultrasound, we can do it abdominally as well as vaginally. When we do a vaginal ultrasound, we have a better picture of the eggs, which we call as follicles. So it is always advisable to have a transvaginal ultrasound, which is called follicular study. We start that from day 10 onwards, every alternate day, and we track the egg growth basically and whether it is releasing. So that is one simple step to identify your ovulation. Second is, I told about the tubes. You've been trying for a year, not been able to conceive, then probably we'll have to think whether your tubes are okay. To check on the tubes, we have three different types of tests. One is something called a hysterosalpingography, HSG it is called, where we inject dye into the uterine cavity and take an X-ray film, and that will tell us whether the dye spills into the peritoneal cavity, which is like whether the dye passes through the tube unobstructed and it comes out into the pelvis. So that is one test. The same test, instead of using a dye, we can use the ultrasound and we can put in, we call this a saline sonography, where we inject saline and see the same thing through the ultrasound. The third would be an invasive test. So ideally, we would be doing any of these two initially, and say supposing they are trying to conceive and not being able to conceive for over probably 5 years, and then we go in for probably a laparoscopy, because laparoscopy will tell us a lot of details. It will also tell us whether the tubes are okay, whether the ovaries are okay, also if there is anything like endometriosis in the pelvic cavity. So all these a laparoscopy would tell. Hysterolap, basically the hysteroscopy and laparoscopy combined together. But that wouldn't be the investigation of first choice. We would reserve it and we would wait until a few years have gone and only then go in for a laparoscopy.
Okay, so that pretty much sorts out the whole procedure and doesn't look as scary as it is, it is in the minds of the couples. I think it looks more
Exactly.
scary.
And see, sometimes they do have a little bit of pain for which we give an injection. I'm talking about the OP procedures. We give an injection prior to the procedure so that they don't feel much pain.
Oh, how lovely! Because HSG, in fact, we have written an article on our website where
Mhm.
we asked our community members that which is the toughest test you have been through, or which was, very painful. And HSG, and that
Yes.
topic article says the mom of
Yes.
all tests,
Yes,
HSG.
yes, yes. Because HSG is painful, but we give the injection prior. And when we do the sonosalpingography, probably the pain is a little less compared to the HSG. But both work on the same way, and we give an injection prior, an hour prior, so that they don't feel much pain.
Great. So all those women who are scared of HSG or are not finding that right doctor who believes in giving the injection pain-free experience of HSG, please reach out to Dr. Soumya. She is in Chennai and is very approachable. She knows about the latest techniques, and the best thing is that as we are talking to her, we can already see that she is ready to understand you and go with you and whatever you want. And I think that is a huge boon when it comes to doctor patient relationship, especially in situations like infertility, when it is a couple that we are dealing with. And a lot of infertility is actually a psycho social issue with a lot of mental heaviness and emotional. So, Dr. Soumya, we also come across many women who have experienced miscarriages while they were trying to conceive on their own. So, is the protocol different for such women when they approach you? And anything if you want to add on that, miscarriages?
See, it depends on which period of pregnancy they've had a miscarriage. We classify it into first trimester miscarriages, which is the first 3 months of pregnancy, and the second trimester. So when they come in the first trimester, when they come in with miscarriages in the first trimester, then we'll have to look into what exactly is the problem, because sometimes, many a times, it is only something to do with the embryo. 95% it is something like a chromosomal disorder in the embryo, or something to do with the egg or the sperm, which is not of good quality, and that is why these embryos don't grow further. Most of the time, that is the reason. But we have another 5 to 10% in which we could have other reasons, like uncontrolled diabetes or uncontrolled thyroid, all those things. And we have something called anti-phospholipid antibodies, which is like self antibodies against body's own antigens. These could all put together contribute to about 5 to 10% of miscarriages happening in the first trimester. Supposing we move on to the second trimester, which is the second 1/3 of pregnancy, that most of the time it could be something to do with the uterine factor. See, some anomalies of the uterus could cause miscarriages, or the cervix is a little shorter. That is the cervix, I mean the mouth of the uterus is a little shorter. And that could suddenly open up in the middle of pregnancy, leading to miscarriages. So first we have to identify what period of pregnancy that she's undergone a miscarriage, and appropriately treat. And any of these, if it's a repeated miscarriages, I don't think people need to worry. We just need to go through all these tests and provide appropriate treatment. But sometimes we have certain, people facing repeated miscarriages. So for these people, we also check the chromosomes of both the partners, the husband and the wife. We have to see whether the chromosome pattern is okay. The chromosome pattern is okay. Then we go into more invasive tests, like we check on the sperms, whether we have something called sperm DNA fragmentation index. All those, we move on to a little more advanced things. If they are having repeated miscarriages, say more than 2 or 3 miscarriages in the first trimester.
Okay. So I think similar is the protocol for the unexplained infertility also, because
Unexplained
there are
infertility,
multiple tests.
they don't even conceive. Here they conceive and then it doesn't proceed. When we talk about unexplained infertility, it is like everything is fine. Here we are trying to find a cause, whereas in unexplained infertility, we have no cause. We've seen everything is fine. Both partners are fine, but still they are not able to conceive. Sometimes,
So
when you have these unexplained infertility, we do believe that there is something like mild endometriosis which could cause, unexplained infertility. Yes.
Oh, so that I think is a very important point for all the couples or women who are listening into us. That if you are going through unexplained infertility, then do check on endometriosis, mild one. Maybe that is the reason, and you can ask your
Maybe.
doctor. Uh, Ask your doctor on that. And similarly, in miscarriages also, if there has been a miscarriage, first please go to a thorough investigation and try to understand what was the reason of miscarriage, because that reason itself will be the solution in the next time when you try for pregnancy, rather than just going for one after the other trials without understanding the reason. So I think that really helps us put things into perspective step by step. Now, moving on to the most difficult conversation for any couple when they are told that they have to go for more invasive treatment like an IVF. Usually, during this, when they are told about IVF, most of the cases the couples have already been through an infertility journey of minimum 2 to 3 years. So they have
Yes.
been through a lot of emotional roller coaster, a lot of financial. They have made a lot of payments and these tests and everything, and there are a lot of hopes pinned to it, to a level where they are very you know in distress and looking for the right solution and looking for that path forward towards parenthood. So, doctor, could you please tell our audiences who are listening into us that at what stage should they start thinking or preparing or considering IVF, or is there any other invasive treatment which is for the advanced patients, and how can they look at it, and what all is involved in that? What would you give them some pointers, quick tips, pointers to manage that phase of the journey?
Yes. See, when we are looking at IVF, first thing is if it's an unexplained infertility, as I said, endometriosis or something we don't even know why, because mild endometriosis wouldn't be obvious. Or if it could be a cervical factor or something to do with the immune system, then we'll have to see what is the reason for this unexplained infertility. If we are not able to pick a cause, then probably we'll have to, it is a good idea to have a laparoscopy done so that even mild endometriosis can be picked up, and probably we could attribute this as a reason for the infertility. But then if everything is fine but still we are not able to find a cause, then I think it would be good to go in for a ovarian stimulation, where we give medicines to stimulate the ovaries to produce more eggs, and we do an IUI. So IUI, probably we could try for about, IUI is like intrauterine insemination, where the husband's semen is concentrated. The best possible, sperms are just picked up, and then that is injected into the uterine cavity, where you bypass the cervix, that is the mouth of the uterus, where you bypass and directly put it into the uterine cavity. Why do we need to bypass the cervix? Means sometimes you could have cervical factors either due to infection or for immunological reasons. The cervix produces a thick mucus where the sperms are not able to penetrate. So when you're bypassing the cervix and putting them directly into the uterine cavity, probably there would be chances of pregnancy. So this we try in unexplained infertility. We probably try for about 6 cycles, and then if it doesn't work, then we move on to IVF. Whereas when we have a cause, say supposing certain conditions, we directly suggest IVF. Like say if there is somebody who has azoospermia. Azoospermia means absent sperms. When the male partner has no sperms, which is in the semen analysis, then probably we would advise. Similarly, when there is tubal block, when both tubes, either by HSG or even when we do an advanced investigation like a laparoscopy and find out that both the tubes are blocked, then we have to move on to IVF. Apart from that, supposing we have people who've been trying for about 12 months with ovulatory disorders. By ovulatory disorders, I mean some hormonal imbalance like PCOS. 12 cycles we've been trying with medication, and still if it doesn't happen, then probably we will have to look at IVF. Also, if there are conditions like been mild or moderate endometriosis, where they've been trying for say about a year or so, still not happening, we move on. We treat like unexplained infertility, and then we move on to IVF. Similarly, for severe endometriosis usually the tubes, everything are all so stuck together that probably it would be a good idea to go in for IVF.
Great, thank you so much, because this you've told everything in such crisp points that, one, we can remember it clearly. Two, it just clears out the confusion, because I love the way you've explained that if there is mild endometriosis, then one can do one thing, and if it is an extreme endometriosis, then there's no point, divvy dabbing or waiting or running around the bush and wasting your time, because as you already said earlier, that age is extremely crucial when you're trying to get pregnant, and anything below 35 is still manageable, still doable, still hopeful. Above 35, things get more complicated. So, Dr. Soumya, thank you so much for explaining all the steps. I think within this 40 minutes of conversation, we've already covered couple who is trying on their own, and then the couple who meets the doctor, what are the initial things and what they should think and prepare themselves. And then going to the non-invasive treatment section, where they are basically trying to diagnose the situation, and then with the help of some supplements, medicines, and injections, they are trying to conceive naturally. And then they move to the minimal invasive thing, which is mostly IUI or some histro labro test, which requires a day of them to
Daycare procedure. Yes, yes.
take care, and not even a day. I think these days the technology is so advanced. Within two
Half
three
a
hours
day.
only they are, yeah, half a day
Yes,
is more
yes.
than enough. So they can plan it on a weekend as well, if they are both of them are working. And then a very small portion of people actually might require to move on towards the IVF. So
IVF, yes.
don't start thinking from backwards, that the moment we land up to a fertility doctor, we have to just start thinking about IVF. IVF might not be the case, or might not be required in your case. So, doctor, before I would like to take a few questions that were coming up. There are a lot of them coming up, but I'll just take a few of them.
Sure,
Uh,
sure.
Here, Shweta Jan is asking that complications are also high these days. Any update on that? I think what she means is that what are the latest complications you have seen or one should be aware of?
Complications related to IVF, or is
Related
it like
to infertility, that what are the complications that
fertility?
increase the chances
Related
of
to
fertility?
fertility treatment is what she's asking,
Yes,
isn't it?
yes,
Yeah.
yes.
So, related to fertility, probably we would say multiple pregnancies. Sometimes we give these medicines where we are trying to make the ovary produce more eggs. So, when we give tablets, sometimes you can have, you're expecting only a single egg to form. But sometimes what happens is you have two, three eggs forming, and then all of them get fertilized, and you can end up with a multiple pregnancy. That is one complication we would take, because though people would like to have twins, it is not always all that simple. Twins or triplets or higher order pregnancy. What happens is, these babies are prone to be born early. They are a little growth restricted. So, or even miscarriages are common with higher order pregnancies. So, we would always try to have a single pregnancy. So that is one complication where you can have multiple pregnancies. The other complication would be we have something called ovarian hyperstimulation syndrome. That usually happens only with injectables, when we give injections for stimulating the ovary. First, we usually try with tablets if it's an IUI. We don't jump into injections. But sometimes there are people who don't respond to tablets, and then we move on to injections. When we give injections, sometimes we face this issue called ovarian hyperstimulation syndrome, where the ovaries respond by producing, they grow too much in size, and they have other effects on the body, where there is fluid collection in the body cavities, and the patient can become a little ill because of that. So apart from these two, I don't think there are any major complications. But generally, when we have assisted reproduction, there is a marginal increase in, of course, miscarriages, also anomalies in the baby. but these are not deterrents to trying any of these methods, basically. So I don't think you need to worry about those kind of complications. Yes.
I think that pretty much sums up. There are risks in every treatment that you go for. No treatment is 100% foolproof. Even as is a small treatment like a fever, you never know. It can just increase so much within hours that you're not able to manage. So, but knowing about those complications is makes you go for that treatment in a very mindful way. So,
Correct.
thank you, Shweta, for asking, and thank you, doctor, for answering it with
Thank
all
you.
the details. And then Malika is asking how to decide for hysterectomy. I think she was.
Hysterectomy.
Ha,
Actually, we are talking on one side about fertility, and here we are thinking of removing the uterus. So, hysterectomy is like a major decision. It has a lot of impact on the mental well-being also of the woman. But having said that, I think when indicated, it is important to go in for a hysterectomy, not for the people who are, in this age group. I'm talking about 45 plus. So for them, they could have problems like, you could have a fibroid, which has been troublesome for the past few years, where they keep bleeding every cycle, they lose a lot of blood, they become anemic, and they're not able to perform their routine activities because of that. Or there could be an excruciating pain every time she has her periods, and she would be wondering, I hope I don't get my periods, kind of. So that is the scenario when, after trying medical treatment for quite some time, say probably for 6 years or 6 months, 1 year, and you have no relief with any of those, then probably you would move on. As for the heavy bleeding, probably you can even try things like, a medicated coil, which would control the bleeding. If any of the medical measures or the coil, nothing helps, then we move on to hysterectomy. I'm talking about benign conditions where you don't have, the urgency to remove the uterus. Yes. Of course,
yes,
for
that's a
cancerous
beauty.
and other things, we have to definitely go in for a hysterectomy. That's a different, topic totally. Yes.
I think that's the beauty of our fertility dose community. When we talk about reproductive health, any questions and all questions are welcome. Or when they see a doctor as charming as you, they are throwing questions from all
Thank you.
sides.
Thank you. Yes.
uh, one more question I think it's really important to take, and it's on mind of a lot of other people as well. That is it safe to start folic supplements in planning pregnancy without prescription? And I also want to add from my experience, doctor, here that I've seen a lot of people continue to take folic acids if their infertility continues, so they're continuously taking the folic acid for a year, more than a year. So are there any side effects in that scenario, and what should we
Actually, just taking folic acid alone wouldn't matter, because excess folic acid is going to be excreted in urine. But if they're clubbing with, they kind of take a whole lot of, minerals, vitamins, all put together.
supplements?
When they keep taking it for a longer period, then probably you would have some side effects because of hypervitaminosis. Otherwise, just folic acid, plain folic acid, you can take continuously till you conceive, because whatever excess is just going to be excreted in urine. Need not worry about taking plain folic acid. But most of the
Okay, so I
prenatals will
never.
contain everything else. Prenatals, or
Right.
even any vitamins, it will contain everything else. So I wouldn't want anybody to take all those endlessly. Probably just folic acid alone would be okay.
I never knew there is a condition called hypervitaminosis. I mean,
That
these days,
happens, for the for the fat soluble. We have something called the fat soluble vitamins, which will be stored in the body. Say, for example, even vitamin D, because most people are deficient. We keep giving vitamin D, and sometimes, they keep taking after our prescription also. So that,
yeah, in fact,
might happen.
this easy availability of medicines and supplements all over the
Hmm.
websites. Uh, you
Exactly.
know, Thank you so much for putting up that disclaimer, because I don't think many of us were aware of this thing, because we everything is like women health support. So you keep buying from your e-commerce websites all kinds of supplements and things. Even there
Most
are
of
supplements
them,
for sugar.
most of them don't have a problem. It's only a few people who, have the problem. That is why it doesn't come to light.
Okay, but yes, but it is important to know about these things. Okay, so let me take the last question of the webinar today. After how many days after miscarriage should one plan baby? Okay, So if a woman had a miscarriage, then after how many days she should plan for her next?
Yes. See, it depends on the period of miscarriage. If it's like sometimes you are just confirmed positive just with a blood test, and then you start bleeding and all that. So the blood test is like less than 1,000. Then I think it is okay to just wait for a month and plan the next month. Just give a month's break, and the following month you can try. But if it's like a first trimester miscarriage, anything before 14 weeks, then I think it's ideal to wait for at least 3 months for the woman to recover both physically and emotionally. If it's a second trimester miscarriage, I would say definitely at least 6 months would be necessary. And sometimes unfortunately, you have, pregnancy losses happening in the third trimester, then I think it would be good to wait for even a year, 6 months to a year before you plan for the next pregnancy.
Okay, so that definitely helps. And thank you, Dr. Soumya. There are so many questions and comments coming up on how interesting the explanation was and easy to understand. And thanks, a lot of our community members are thanking you. So thank you so much
Thank
for
you,
your time.
everyone. Thank you, Geetanjali, for having me here. It was really nice talking with you. So I actually enjoyed these 40 minutes of conversation with you, actually.
We look forward to having you again, because I don't think we have been able to justify all the questions that the people were asking in the group. I could only take a few of them, which I thought will impact a lot of others also who are watching us
Right.
now and will continue to watch us ahead. So, thank you, Dr. Soumya, for coming to us. And friends, if you are in Chennai and going through, I would say, not just infertility, but any problem related to your reproductive health, you should at least reach out to her and speak to her and see. A lot of times just talking and knowing what lies ahead also solves a lot of problems. So thank you, Dr. Soumya, for coming to
Thank you
us.
so much. See you. Bye bye.
Bye bye.